Hi, my name is Peterson. I'm a board-certified reproductive endocrinologist and infertility specialist. I work at Nevada Fertility Center, and today we'll be talking about IUI. What is IUI? IUI stands for intrauterine insemination. It's a process by which we place sperm up higher in the reproductive tract in order to optimize the number of good sperm in the right place at the right time, hoping to increase your pregnancy chances. For a typical IUI, we bring patients in for baseline ultrasound to verify that the ovaries are resting, and then we start them on medications, typically Letrozole or Clomid. An IUI cycle takes place over a typical menstrual cycle, roughly 1 month. It is broken down into roughly 2 weeks of meds monitoring and an insemination procedure, followed by 2 weeks of waiting to test for pregnancy. You'll typically do a baseline ultrasound around cycle days 3 through 5 to verify that your ovaries are resting. Then you'll be given oral medications for about 5 days to help recruit growth of eggs in what we call follicles. These are fluid-filled spaces within your ovaries, each containing an egg. You'll likely return around cycle day 10 through 13 for a follicular ultrasound to track recruitment and growth of these follicles. Once they reach an appropriate size, we initiate the ovulation process by giving you an injection we call the trigger shot. An intrauterine insemination, or IUI, is typically done 24 to 36 hours after the trigger shot to ensure that motile sperm are present in the uterus near the time of ovulation. We're basically optimizing the number of good sperm in the right place at the right time by controlling key events of the cycle. So the average patient will need maybe 2 to 3 ultrasounds to monitor throughout the process for an IUI cycle. After the insemination, the patient will wait 14 days before we do a pregnancy test to verify that it was successful. So good candidates for an IUI cycle are patients who have adequate ovarian reserve, they have normal uterine testing, meaning a cavity without any problems inside of it, open fallopian tubes, and a partner or a sperm source with adequate sperm parameters. So patients who tend to do well with IUIs are those who don't actually have a history of infertility, but require an IUI for one reason or another. Sometimes are same-sex couples or those who need donor sperm inseminations for a variety of reasons. Other patients who tend to do really well with IUIs are those who have issues with anovulation, where we can easily induce ovulation with medications. They tend to have higher success rates with IUI cycles. So patients with unexplained infertility, meaning their testing was normal, but for some reason or another they're not getting pregnant on their own, do see improved pregnancy rates with IUI, although it is more limited, maybe 7 to 10% per cycle if they have unexplained infertility. Patients that don't do as well with IUI cycles may be patients who have diminished ovarian reserve in combination with advanced age. So patients over the age of 40 tend to have lower success rates with IUI. It doesn't mean they can't do them, but we do have lower expectations for success. How much sperm do you need for an IUI? Many practices use a total motile count before the wash to determine whether it's adequate for an IUI. A pre-wash total motile count of 10 million is a fair estimate for adequate sperm for an IUI. And I say estimate because it does have to go through a wash process, and we expect to lose about 30 to 50% of the total motile count after the wash. The hope is that you have greater than 5 million after the wash. Now, can people get pregnant with total motile counts less than 5 million after the wash? Absolutely. It happens all the time. But there does arise a question of cost benefit when we have sperm counts below 5 million. Why do some patients go through timed intercourse before going through IUI? In patients where the male has a total motile sperm count greater than 75 million, it's unclear whether IUI adds any benefit. Some may choose to do timed intercourse cycles as opposed to an IUI to save on the extra cost if there is no perceived benefit. So general success rates for IUI for the first, second, and third cycles are largely going to depend on the diagnosis. But if we're talking about average pregnancy rates for IUI cycles being between 10 to 20%, if you were to do 3 cycles, over 3 cycles, you would expect 30 to 60% of the patients to become pregnant. The pregnancy rates per cycle stay relatively constant for the first 3 cycles. But after the 3rd cycle, we start to see a drop in the pregnancy rates per cycle. So Letrozole and Clomid have different mechanisms of action, but result in largely the same effect, which is they cause your brain to release more FSH from the pituitary and recruit follicles in the ovaries. Clomid is a selective estrogen receptor modulator, which basically just tricks your brain into thinking that you don't have estrogen, so you release more FSH from the pituitary, resulting in follicular recruitment. Letrozole works by blocking an enzyme in your adipose tissue called aromatase. By doing so, it creates a sensible reduction in estrogen levels, and so your brain will release more FSH and recruit follicles. For questions in relation to Letrozole versus Clomid, they can essentially be used interchangeably without affecting the pregnancy rate by very much. There are some nuances. In Letrozole, for patients with anovulation or PCOS, it tends to work a little bit better. Clomid may have a small advantage in patients with unexplained infertility, where our goal is to recruit multiple follicles. So how many IUI cycles should one try before moving on to IVF? After about 3 to 4 cycles, we see a decline in the benefit from IUI cycles. In fact, after 6 cycles of IUI, we see no benefit over trying on your own. So after 3 to 4 cycles is a great time to start considering whether you should move on to IVF. Is the IUI procedure painful? To perform an IUI, your physician has to place a speculum inside the vagina and pass a catheter through the cervix. So under normal circumstances, one shouldn't feel more than mild discomfort with the procedure. Do you have to lay down after an IUI? No, numerous studies have shown that whether a patient lies down for a period of time or they get up and move around immediately, neither has an effect on the success rates of an IUI. Can you work out after an IUI? Yes, there are no restrictions on activity after an IUI. Going through fertility treatments can be riddled with anxiety and stress, and exercise can be a great stress reliever. Can you take a bath or swim after an IUI? There are some centers that recommend a 24 to 48 hour wait before bathing or swimming. There are, however, no data to suggest that this is necessary, so yes, you can. So what if you only have one blocked tube and one open tube? Can you still do IUI? Yes, you can. Practitioners usually will want to focus on ovulating from the side where the tube is open. If you ovulate from the opposite side, it may reduce your chances of pregnancy. How much, we don't know. So depending on who your practitioner is, they may recommend canceling if you develop a follicle on the side of the closed tube, or they may say we can go forward, understanding it may not be optimal. One thing to keep in mind is that if you do have one blocked tube, whatever process caused it to be blocked may have also caused damage to the function of the other tube that remains open, and it could reduce your chances overall. Can a patient do anything to increase their success with IUI? Most recommendations in this category are going to be general opinion regarding general health and well-being. So I would recommend doing whatever helps you feel the best, and not stress yourself out with hearsay, wives' tales, or unproven treatments that you read about on social media. reassure yourself that you're doing evidence-based practice with your physician doing an IUI, and trust that you'll have the success rates that are expected.